Hello everyone and welcome back. So in this video we will revise all infectious diseases and all the important questions and topics in the infectious diseases. So we will start from the first, that is measles, and we will study all the important clinical features of all the infectious diseases and how we will differentiate each infectious disease from the other. We will discuss it in this video. So we are having the measles. There is a scenario that there is 11 months old who come with coryza like signs and high grade fever but no skin rash. Mother is afraid of measles as there are few cases of measles in the neighborhood, and doctor examine infant and check his mouth from inside and tells mother that infant has measles. Now how doctor can say that there is no skin rash? How many doses of measles vaccines are recommended and at what age, and what is the incubation period, and what are the type of rashes of measles and 5 complications of measles. Another scenario is that there is a 1-year-old child who has fever for last 4 days, and he is having runny nose and cough and conjunctivitis, and the mother has noticed some rashes over body since morning behind the ear and on face and upper chest. Mother told that the child has missed his last vaccine due to her illness. Okay, so here in this scenario it is clear that we are having the history of high grade fever. This is the one feature. Then another one is the skin rashes. The skin rashes may be present or maybe not present, but the rashes start in measles from mouth and ear, so the rashes are present there. Another clinical features are that the rashes are present behind the ear and face and then on the upper chest. And the mother also mentioned that the child is not vaccinated. So you have to answer all these questions, that how many doses of measles vaccines are recommended, and what is the incubation period, and what are the complications of measles. So the definition is that measles is acute and highly contagious viral disease. Measles is caused by virus and it is characterized by final stage of maculopapular rash erupting successively over the neck, face, body, arms, and legs, accompanied by a high grade fever. So these are the diagnostic points, that there will be high grade fever and maculopapular rash, and successively over the neck and then the face and the body and the arms and legs, and there will be high grade fever. Now the causes of the measles is RNA virus. Measles is a viral disease. Now the complex spots are present in the measles, and these are manifesting 2 to 3 days before the measles rash itself, and they are characterized as clustered white lesions on the buccal mucosa and opposite the lower first and second molars, and are pathognomic for measles. The finally rash is appear, and the fever is 101 degree Fahrenheit, that is high grade fever. And exanthem, that is maculopapular rash, starts at head, the nape of the neck and behind the ears, and spread downward in fans in some manner. So you should remember that the complex spots appear in the measles, which are white lesions like spots on the buccal mucosa, and then it spread towards the nape of the neck and behind the ears. So this marks us that this is a viral disease, measles, and it is accompanied with a high grade fever. Now the clinical investigations that are done for the measles to confirm the diagnosis is that clinically during prodromal stage multinucleated Gantt cells can be demonstrated in smears of nasal mucosa, and virus can be isolated in tissues culture, or antibody titer can be detected in serum. As it is viral disease, so virus will be detected. White blood cell count is low with relatively lymphocytosis, and lumbar puncture in encephalitis shows an increase in protein and small increase in lymphocytes. If you do the lumbar puncture, then there will be increased proteins in the CSF, and there will be small or a little bit increase in the lymphocytes. Okay, the clinical investigations to confirm the diagnosis. So the clinically these things will be present, that is prodromal stage multinucleated Gantt cells, and in viruses isolated, and on lumbar puncture proteins will be increased. Now the differential diagnosis of measles are Rosella infantum, rubella and echo and Coxsackie infection, scarlet fever, meningococcemia, and drug rash, and serum thickness, and erythema infectosum. These are all the differential diagnosis of measles. The same features also appear in this, but specifically in the measles there is high grade fever and complex spots, which later change to the rashes behind the nape of the neck, the ear, and the chest and arms. The complications of the measles are respiratory system complications, that is encephalitis and subacute sclerosing panencephalitis, hemorrhagic measles, thrombocytopenia, GIT complications, eye complications, and heart complications. All this can occur due to the measles. The management option for measles is that supportive treatment is provided, that is hydration and antipyretic, that is brufen and paracetamol can be given. Vitamin A is given given for reducing the complications which is caused by the virus. Is virus can affect the eyes and it can lead to blindness. So vitamin A is given. Vaccine is administered at 6 and 9 months of age. The vaccines for measles are administered at 6 and 9 months of age. There is MMR, which is present in the EPI schedule. And two doses are given. One is given at 12 to 15 months, and the other one is given at the 4 to 6 years of age. Now, after the exposure, if the vaccine is not administrating, then what is done after the exposure? At the age of 0 to 6 months, immune serum globulin, if mother is not immune, and if pregnant lady, then or she is immunocompromised, then immune serum globulin is given, and all others are vaccines within the 72 hours for susceptible individuals. If the patient is not vaccinated already, then this treatment plan is provided, and to the mother, the immune serum globulins are given, and all other patients are given the vaccine within the 72 hours of the infection. Okay, so this was all about the measles. Now coming toward the enteric fever. Here is a scenario that there is a 8-year-old girl in unwell for last 10 days, and she is having fever, anorexia, and pain abdomen, and she has used amoxicillin and anti-malarial, but no improvement in fever. On examination, she is febrile, ill-looking, and lethargic, as well as dehydrated, and her tongue is coated. There is mild hepatomegaly. Okay, so these are the clinical features that there is a patient who is having fever, unwell, and for last days having fever, anorexia, and pain abdomen. This is the most important feature. Another thing is that she has used amoxicillin and anti-malarial drugs but not improvement. It means that in this scenario the malaria case is excluded. If it was malaria, then there must be the relief of pain and temperature by using the amoxicillin and anti-malarial drugs, but the malaria is excluded here. So she is febrile, that is she is having fever and ill looking and lethargy, as well as dehydrated, and her tongue is coated. This is another feature of the enteric fever. And hepatomegaly, these are the important features. In hepatomegaly, pain abdomen is present, fever is present, dehydration, ill looking, febrile, lethargic, and hepatomegaly. The pain abdomen, hepatomegaly, and coated, these are the differentiating points for enteric fever. Okay, so what is the diagnosis, the investigation plan, and name the first and second line drug for the treatment, and what are the two complications and two important preventive measures. So the enteric fever is caused by Salmonella Typhi, and the incubation period is 7 to 14 days, and the mode of transmission is fecal oral, and outbreaks of disease may occur by contaminated water or ingestion of contaminated eggs. So we should remember this point, that the transmission of enteric fever is fecal oral, and it can be transmitted through ingestion of food or contaminated eggs. Now the investigations for enteric fever are that in first week blood culture is done, in second week agglutination or Vidal test or typhoid test is done. In Vidal test, O antibody and H antibodies are checked. O antibody in the 1:160 is suggestive and diagnostic, and the H antibody signifies the previous infection. We will do the Vidal test in the typhoid. If H antibody is present, then this shows that the previous infection was present. If there is O antibody, then this gives us the diagnosis of the enteric fever. Now in the typhoid test, we will check for the IgG and IgM antibody. If the IgM antibody is present, then it means that this is recent infection. If IgG antibody is present, then this goes give us the diagnosis of the remote infection, that is a past infection. At the third week of the enteric fever diagnosis, stool culture is done, and if it is the fourth week, if the patient arrives with the fourth week, then urine culture is done. So these are the specific investigations for typhoid which we should remember, that is Vidal test, typhoid test, and urine culture and stool culture. So stool culture is done at the third week, urine culture at the fourth week, and typhoid and Vidal test gives us that whether it is the recent or active infection, or it is whether a past infection. Now the management options for the enteric fever. So supportive treatment is provided, that is proper hydration and nutrition is done, blood transfusion is done if needed, and if intestinal perforation is present, then surgery is done. Okay, and the specific treatment options are that antibiotics are given, that is ceftriaxone and cefixime, and fluoroquinolone such as ofloxacins are given. The prevention of typhoid fever is done by hand washing and improved hygiene and clean water. Eggs should be thoroughly cooked and never eaten raw, and passive immunization is done, that is vaccine 0.25 ml subcutaneously, and oral vaccine is given for capsules on alternate day in children older than 6 years. Okay, so the vaccine for typhoid fever is not present in the EPI schedule for the babies, but vaccines are separately present, and these are given as the 2.5 ml dose, and it is given subcutaneously. And if it is given orally, then Vivotyph is given, and 4 capsules on alternate day in children is used other than 6 years. Okay, now the first and second line drugs for the treatment of typhoid fever are chloramphenicol, which is 50 to 70 mg, ampicillins, amoxicillin, trimethoprim, fluoroquinolone, ceftriaxone, ciprofloxacin, azithromycin, and cefotaxime. These are the specific drugs or antibiotics which are used for the enteric fever or typhoid fever. These are the differential diagnoses, that is gastroenteritis, bronchopneumonia, sepsis, malaria, tuberculosis, hepatitis, amoebic liver abscess, shigellosis, milieu TB, bacterial endocarditis, infectious mononucleosis, malignancies such as leukemia or lymphoma. And the complications are intestinal perforation, intestinal hemorrhage, toxic encephalopathy, acute cholecystitis or hepatitis, pneumonia, pyelonephritis, meningitis, osteomyelitis, septic arthritis, sepsis, and toxic myocarditis. So these are the complications of the typhoid fever. All the things are common which we have already discussed again and again, but you should remember this, that the vaccine for the typhoid is not present in the EPI schedule, and the specific vaccine that is given for this patient is the TAB vaccine, which is 0.25 ml in dose, and it is given orally. If it is given orally, then Vivotyph is used, and 4 capsules on alternate day in the children, then 6 years is used. And these are the drugs that are used for the typhoid fever. Okay, now coming towards the third infectious disease, that is diphtheria. We have discussed the enteric fever and we have discussed the measles. Now coming towards the diphtheria, there is a 3-year-old boy presented with history of lower limb weakness for last 3 days. Past history revealed UTI 3 weeks ago with swelling of neck and nasal tone in speech, and he is unvaccinated and belongs to poor family. Temperature is 98 and heart rate is 90 with irregular rhythm, deep tendon reflexes in lower limbs, and diminished gait reflex is also poor. Now in this scenario, there is history of the weakness of lower limb, and also the history of UTI infection, and also there was swelling of the neck and nasal tone in speech, and he is not vaccinated and belongs to poor family, that is poor socioeconomic status. He is having the mild fever and irregular rhythm and heart rate. Okay, so this is diphtheria, and the investigations that are done are a direct smear, that is swabs from the suspected lesions is taken, and culture is done, that is the isolation of the organism on culture confirms the clinical suspicions, and CBC is done, which shows us slight leukocytosis. The differential diagnosis of diphtheria are pharyngeal diphtheria, laryngeal diphtheria, neuropathy due to diphtheria, and nasal diphtheria. In pharyngeal diphtheria, we are having the acute streptococcal pharyngitis, thrush, hepatic infection, agranulocytosis, and infectious mononucleosis. In laryngeal diphtheria, we are having acute epiglottitis and laryngotracheobronchitis, and the rest are nasal and neuropathy diphtheria. Now, the management options for diphtheria are that there are 4 major steps. First of all, supportive care is provided, that is bed rest. Then you should treat the complications such as respiratory compromise, heart failure, renal failure, and cardiac arrhythmias. Then the isolation of the patient is done, and diphtheria antitoxins are given, that is dose of antitoxin based upon the site and extent of local infections and severity and duration of symptoms at the time of presentations. Antibiotics are given, that is penicillin or erythromycin is the drug of choice, and the treatment of carrier is erythromycin or penicillin. The prevention is done by immunization, that is immunization with DPT, diphtheria toxoid combination with pertussis and tetanus toxoid, and the care of the exposed susceptible is done. Okay, so if you are having a scenario or a clinical case that the patient is unvaccinated and now he is having the weakness of the lower limb, and he was having the history of UTI, and also he is presented with the swelling of the neck and the nasal tone in speech, so this gives us the diagnosis of diphtheria as it is due to the post-infectious, and we will do the direct smear, the culture, and CBC for the diagnosis of this disease. And the differential diagnosis are pharyngeal diphtheria, laryngeal diphtheria, as throat is involved in this disease. So the pharyngeal, laryngeal, the nasal, and the neuropathy, all these are the differential diagnoses, and there are specific supportive treatments, that is supportive care is provided, and antibiotics are given to the patient, and the prevention is done by the vaccination of the patient. Now the next topic is tetanus. The scenario is that there is a 10 years old boy and he had a roadside accident, and a week ago he had a lacerated wound on the dorsum of foot. Now here is he is having a history of the wound. He has took his dispensary where he was given the stitches and was sent home on some medication. Now for last few days he has difficulty in opening mouth and taking food. Since yesterday he is also having toxic clonic fits. During fits he remains conscious but passes urine and stool. So here we are having a patient that he is having a RTA, that is roadside accident, and he was having a wound and the wound was stitched. So now he has developed the some features, that is clonic fits, and he remains conscious but passes urine and stool. So if there is a history of wound, then from the wound the infectious disease that can develop is tetanus. So the introduction of tetanus is that it is acute spastic paralytic disease, and the causative agent is Clostridium tetani, which is spore forming bacteria, and the mode of transmission is spores is present in the dust, soil, and it can get into the body through the broken skin. Now, the differential diagnoses of the tetany are bacterial meningitis, encephalitis, and strychnine poisoning, birth trauma, epilepsy, rabies, and abscesses. The following conditions that are present, that is lacerated wound, then stitched, then the patient is conscious but he is passing urine and stool, and he is having toxic clonic fits. So these are the features of the tetanus, and these are also may be present in the rabies, the epilepsy, the birth trauma, the bacterial meningitis. So all these are the differential diagnoses of the tetanus. Now the management options are supportive and specific. In supportive, the good nursing is provided, placed in dark room with minimal voice, and give adequate fluid, oxygen, and suction when necessary. And the specific treatment is that anticonvulsants are given, for example diazepam for fits, and for human tetanus immunoglobulin is given, which is 3000 to 6000 units intramuscularly, and penicillin G is provided for 10 to 14 days, and gentamicin is given. The prevention is done by DPT immunization, that is diphtheria, pertussis, and tetanus. And tetanus is prevent by the following agents. The supportive treatment is sedation, feeding, and nurse care is provided. These are the complications of tetanus, that is aspiration of the secretions and pneumonia, lacerations of the tongue due to seizures, and seizures may cause intramuscular hematoma or leading to hemoglobinuria and renal failure, vertebral fracture during seizures, and decubitus ulceration and autonomic disturbances. These are the complications of the tetanus. Now the unimmunized person, for the unimmunized person, the specific treatment is that give ATS, that is intramuscular, give first dose of the TT vaccine at same time but different site than ATS, and give second dose of TT after 6 weeks, and give third dose of TT after 6 months. In fully immunized children, single dose of TT if last dose was given more than 5 years back. This is the specific treatment for the case of tetanus. That is, the prevention is that the DPT vaccines are given, but if the vaccines are not given, then this is the treatment for unimmunized person, and this is the treatment option for the fully immunized person. So we will identify the case of the tetanus by these features, that there will be the history of RTA or any other cause which can lead to wound and stitches, and then from this the features of the consciousness and passing urine and the clonic fits can appear, and it can be prevented by the tetanus vaccines. Now coming towards the next, that is malaria.